Welcome to Make America Healthy Again. Join Dr. Charles Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
This is the Make America Healthy Again podcast. This is Dr. Charles Antinori. And today I got my nephew and godson. That's right, my godson too. Chavez Carey, who's a young family practitioner, and we'll talk about things from his point of view. Hey, Joe.
Hi, good morning. Good morning. Yes, thanks for having me on. This is fun. Appreciate it.
Good. Why don't you just kind of briefly go over your background, where you came from, et cetera, training, that sort of thing.
Yeah. I graduated medical school a while ago now, 2006 at NYU, and then I did my residency in family medicine in California in the Bay Area at a regional hospital called Contra Costa in a little town called Martinez. And I worked out there for a while, which was a county health system, which was, almost 100% Medicaid, Medicare, kind of underserved population. And now I'm out here in the East Coast, working for another small regional kind of hospital health system. A little bit more of a mix, payer mix, commercial, private, but it's a lot of fun. I'm the director of primary care at the organization. I work with residents. I work with medical students. So we have a really good time. I enjoy it quite a bit.
Great. Yeah. In case there are any Yankee fans watching, I want to point out that Martinez, California, where you worked and where I visited you, is where Joe DiMaggio was born, yes, and where he married Marilyn Monroe.
That's right.
I remember we went to the house. Yeah.
And it's funny because it just gives you a sense of like the times, because it's kind of just a regular house. It's even a small, humble little house for these two massive stars. So it just gives you a sense of how things have changed a little bit. But yeah.
It was so amazing to see the place. And by that time I came visit. I also can't believe that you graduated medical school in 2006. It's been 19 years already. Holy smokes.
I know. It's actually pretty great right now. I feel, I've kind of finally gotten my 1,000 hours plus or whatever. And, you're kind of like, okay, I think I can I'm actually pretty good at this now. So
what's your 1,000 hours? What's that?
No, it's like that's this thing about I forget whether it's 1,000 hours or what, but becoming an expert at something. Yeah.
Oh, I see. Okay.
Yeah.
So you're enjoying the work and you feel good with it, huh?
Yeah. Overall, it's great. I do. When I was in residency, I went to this residency program where they were, it was really a broad spectrum in the sense of, we did labor and delivery, we did C-sections, we were assisting in the OR, we did the ER, the ICU. We basically ran the hospital. Now just doing like everyday, regular kind of clinic work, I've actually surprisingly found it pretty great. Just kind of meeting people and getting to know folks and really valuing that piece of it.
One of the things we said we wanted to talk about was the newer business models for family practice that you were talking about, some of the residents have been talking about.
Yes. So, anyone who's kind of been paying attention to, medicine, especially primary care, outpatient medicine, there's definitely been this trend towards, doctors. Years ago, it was almost 100%, self-employed, independent practice. And now it's, definitely minority. Most, are employed by a group. And I've seen over the last couple of years, some of the residents, going out and trying to start their own practice. So this idea of what's called direct primary care, where there's a, kind of like a monthly subscription, fee. And, it's not like there is something called concierge, but, that's a little bit higher, touch, higher level, where that's, higher fee. But this is more of like an everyday, almost like the cost of a gym membership, $75 to $100 a month. And it's just a cash-based model, basically, kind of leaving behind, insurance, because that was the bugaboo that drove many people out of private practice, and including, I think, my dad to some extent. Just battling insurance companies. And so moving to a cash-based model, it's just been interesting to see that happening.
we should point out that your dad, my brother-in-law,
Yep.
been a family practitioner for what, about probably close to 50 years, huh?
Yeah, 40, like
Yeah,
45. Yeah,
yeah,
yeah, for sure. And
yeah,
he lived through that whole, I mean, that whole arc of, I don't want to speak for him too much, but like, like starting out in like 1980 kind of,
yeah,
when it was just basically like, yeah, most people didn't, I mean, people had insurance, but essentially the doctor could charge what they thought was appropriate for their services, to the 90s and early 2000s with kind of managed care where you would sort of get what the insurance company wanted to give you or didn't
right.
want to give you. And so that was I think a really rough time in private practice. And so that's when you saw a lot of people move to the employed model, and it's still a struggle this day. I mean, I see my staff battling for prior authorizations. I mean, it's still a huge problem.
Yeah,
And so I think a lot of people are just like, you know what, I just want to do my job, and I just want to go out and say, hey, here's what I can do for you, and here's what I'm asking you to pay me for this service. And they kind of work out a deal, almost like it's interesting. It's almost like returning to an old fashioned kind of way of doing things.
yeah. It's interesting, Joe. I talk about it in the book too, to make America healthy again. Um,
Hmm.
Medicare got passed in like 65. I started residency in 73. And so there were still a lot of surgeons that practiced, mostly the senior surgeons at Columbia, as a Columbia Presbyterian, had practiced for most of their career in the pre-Medicare era.
Right.
And the doctors fought Medicare like tooth and nail. I followed
Yep.
it like while I was in high school because I already knew I was planning to go into medicine. And by fighting it, they lost, but they got a great deal initially. So initially, when Medicare came in, they gave you 75% of usual and customary, but nobody really got usual and customary. Like
Yeah. Yeah.
the
Right.
number that
Right.
you asked
Right.
for was not what you got paid, back then. And I always say it was like whenever we would present at our M&M conferences, we'd present every complication, no matter how minor. And every
Hmm.
time you present the complication on like an older guy, and in those days, like 70 was old, we present a hernia that had a complication of some sort, and one of the old attendings would say, "Why are you fixing a hernia on a 70-year-old guy?" Because before that, if you did surgery, before Medicare, if you did surgery on an elderly patient and something went wrong, you might bankrupt the family. If they ended up spending a month in the hospital or something,
Hmm.
they might not have the money to pay for it. But
Yeah.
Medicare coming in ushered this unbelievable expansion in medical care. That's where all the heart surgery and everything, came in and grew, because for like about 25 years, up until about 1990, was that 25? Yeah,
Hmm.
25
Hmm.
years,
Yeah.
you got paid, whatever, pretty much, just very, very well by Medicare. And
Right.
then around the 1990s, they all of a sudden discovered that, hey, we're spending an awful lot of our gross national product on healthcare, more than like other civilized countries. And this is still a battle that's going on now. It's around, I
Yeah.
think, 18% or something of the GMP
Right.
is for medical care. And that's when they started cutting, and that's when HMOs and everything came in. And like you said, I
Yeah.
remember for a while they gave your dad a really good deal. And that's how they all do it. And
Yeah.
the
Yeah.
same
Yeah.
thing
Yeah.
happened with
Yeah.
Medicare. In the beginning, you had a really good deal, and then really ever since 1992, it's been getting cut with relation to inflation, at least.
Yeah.
It
Yep.
either gets outwardly cut, overtly cut, or just cut in terms of the relationship to the cost of living. I
Hmm.
think in a
Hmm.
book I mentioned, I don't remember the exact time period, but it was about like 20 years or so. The
Hmm.
Social Security cost of living increases had gone up about 54% or something like that. And
Hmm.
the increases in medical reimbursement went up like 5%. So basically, in other
Right.
words, you were being paid half in terms of buying power what you were being paid 20 years earlier.
Yeah.
And
Yeah. 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 Yeah.
that a lot of that is what, and again, the cost of running a practice, the aggravation of running a practice, if anything, got worse.
Right.
With
Right.
as you pointed out, with pre-authorizations and staffing and everything else, and buying health insurance for yourself and buying health insurance for your employees.
Yep.
It just got worse and worse, and that really was a big factor driving guys like into employed situations.
And group
Right.
yeah, so the idea is kind of like you just strip all of that away and get back to basics. I mean, and patient would still carry their insurance for like that hospitalization or that medication or whatever it is, but you wouldn't be billing the insurance basically. But
right. Yeah. Well, so the administrators do that for you. You still have to do it. I mean, I still, actually, you still have to code. Really, the other thing, really the biggest thing, and I think the two biggest things that really drove, if you look at the statistics, again, I don't know specifically about family practice, but I know about surgery and I know about, medicine in general. The two things that really drove huge numbers of doctors to go into employed situations were the Affordable Care Act and the High Tech Act. The Affordable Care Act. It turned out, I mean, I think everybody suspected, I know I suspected it to be exactly what it turned out to be, which was basically a huge expansion of Medicaid, and again, for listeners that don't know, Medicaid reimbursement is incredibly low. It doesn't cover the cost of the expenses of running an office in most states. It varies from state to state, but any place in New Jersey, I can tell you and I'm sure in New York it's the same way. It's really very bad. So they do reimburse hospitals, reasonably well because they don't want hospitals closing. They reimburse hospitals near the real cost of things, but they don't reimburse physicians. For example, one of the biggest examples that always bothered me is that there's so many patients now that have Medicare and Medicaid. Medicaid becomes their secondary insurance, like especially if you're going to go into a nursing home or something like that. I'm sure you deal with that a lot, right? Where Medicaid becomes a secondary. Well, the original deal with Medicare, again, back in '65 when it was started, was that the government would have give you an allowable number. Let's say we're talking about gallbladder, and so to make it easy, we'll say make a round number like $1,000 that they allowed for a gallbladder cholecystectomy, and so they would pay you $800, and then the patient was responsible for the other 20%, and that's where the secondary insurance companies came in. People would buy the Medicare supplement plans, which they still do, and now they're doing the Medicare Advantage, which sort of takes over that Medicare supplement area. And the supplement would pay the 20%. And then, like we used to say to patients all the time would ask us, we do a heart surgery operation, it would cost, let's say, $5,000, and we get $4,000 from Medicare. All the patient had to say to us was, Doc, I'm living on a fixed budget. Could you do something about that extra 20%? And we always gave up that extra 20%, that $1,000. If we got $4,000 for open heart, we were very happy about it.
Yeah.
When Medicaid gets involved in the act, they just say, we're not paying that $1,000. They basically just abrogated the deal that was made originally with Medicare. When Medicaid becomes your secondary, they say, well, look, Medicare paid you $4,000. That's more than we would pay. So, you're not getting the other 20%. And again, it took it away. It took the charitable aspect away from the physician. So that that sort of thing really drove a lot of people toward.
Well, yeah, and you don't have like the control as someone who doesn't kind of work for yourself. You can't make those kind of decisions. You just there's some billing office somewhere, and that I think that makes things worse for patients because now, I mean, another trend, and we didn't really talk about this, but I think we're guilty now in medicine of participating in what I call like the great runaround. People are just dragged through like endless layers of bureaucracy for everything they want to do if they have a question or if they need. It's just, I think another big downside of like corporatization and employed model is just it takes away the personal, small one-on-one, you can actually call and talk to a person. I hear complaints about that all the time.
Let me give you my example of that. I'm going through, I had kidney stones, so I have a urologist. And there's the company in I shouldn't mention any names, but let's just say that one private company basically took over, is sort of a big entity that is basically employing, I think, pretty much all the urologists in New Jersey. I'm sure it's not all the urologists in New Jersey, but it might be like maybe 60, 70% of them, So, and I went, I had an office visit with my urologist, who I love, who was really a nice guy. And I've known him for, 40 years probably. And, every day I'm getting emails that I owe them $20 and letters that I owe them $20. And I paid the $20 and I still keep I called them up. I actually got somebody on the phone and called them up and said, no, you don't owe any $20. And yet, the next day another bill comes for $20, for my copay for this visit, so it is. And when you try to call their office, you got to go through like 9 screens of, which office are you talking about, which doctor, which office, where, there's like 6 things you have to go through before they can route you to the right person to talk to, It has gotten so big. Yeah. The other thing about it, as I said, drove a lot of doctors, including me, was the High Tech Act, where they said you have to have a computer. That was 2014. And again, if you look at the statistics and the number of employed physicians, that's when it really started. Right before that and right after that is when it really, really shifted to. Now I think something like 70 or 80% of physicians are employed. Before that, it was like maybe 20 or 30%.
I think it's in the 50s.
I did want to say I am happily employed. If my employer were to ever watch this or listen to this podcast, I'm very happily employed. Please don't take that the wrong way. But no, and then just in general, why do we have a shortage of primary care doctors, right now in our country? Just kind of talking about that, barriers to applying to medical school, to residency. And then once, you get into medical school, barriers to choosing family medicine primary care because it doesn't get paid as much. And it's sort of seen as maybe less respected and more, harder in terms of administrative work and things like that. So I think that's a big problem that we have right now, is just people don't really have the ability to get in to see a PCP. Right now, people tell me like, Doc, I've been waiting months to get in to see you as a new patient. I have a couple thousand patients already, and so we have to limit my schedule. And I think there's a lot of problems when you don't have patients who have like a good relationship with a regular primary care doctor. I think it just continues to, it's not good for health. It's not good for people's health in general. It's not good for, trust in the health system, right? If you're kind of pinging around to different, God bless our specialists. I love them. But if you're just kind of pinging around to different specialists, you're going to not feel great about, I think, healthcare. It's not going to give you that good, strong, trusting, long-term relationship with somebody. So I think it's something that we need to work on.
It's interesting that I just did a podcast a week or two ago with your uncle Joe, my brother, and also in family practice. He said kind of the same thing. Like he was saying how, like, as he went through medical school and residency, medical school, the professors almost sort of tried to talk him out of family practice. Like that they didn't think he was going to be happy. That sort of thing. And so it's funny. And I'm reading a book now. Just started it a couple days ago. The best 10 healthcare systems. They're looking at the United States healthcare system, and Canada, Japan, China. A bunch of big ones. The Scandinavian countries, and I don't know. Again, but it was interesting. They gave a lot of very interesting. He starts with the American system, and he gives a lot of interesting statistics. And one he threw out was family practitioner. I think he said the average panel is like 3,000 or 4,000 patients or something like that.
I wouldn't be surprised. I would not be surprised. It's too many. Yeah. And what that creates is like when when you're sick, when you have a cold, something comes up, I'm already going to be like triple booked on my day, and then now you've got to go to urgent care, and maybe then you don't really think I care about you or something, So, I think I don't know like the evidence for this, but I think a health system that like has a good, strong, confident, smart, enabled primary care base is going to be a better health system. I think that's just got to be true. I think what the other problem is, like, especially I've seen the difference practicing in California versus New York. Out where I practice, it was kind of a little bubble where family medicine really was encouraged and empowered to do a lot, do a lot of procedures, do a lot of different, care for different things. Out here, it's a little bit more, it feels like there's so many specialists. You're kind of like feeling like, well, I could do this, but they'll probably do a better job, So I think it erodes your skills a little bit when you practice in that environment. But it's also probably not, there are a lot of things we really can do. And some in like a city or urban environment that I think we don't, and that's another issue within the specialty itself. But
like you're saying, assisting in surgery, that's first of all, it's very interesting, and it used to be pretty lucrative, but it's since they've cut everything down, it's not horrible, the reimbursement for assisting at an operation. It's not as great as I knew guys when I trained. There were guys that never got a really good practice going, in a hospital, and but several hospitals I worked at, and there would be a guy who was like really pretty busy, but he'd be helping the really busy guys. There's always like 2 or 3 surgeons in a hospital that are jammed, and a lot of times they need an assistant, and if they don't have a partner or something like that, that's where these guys would fit in, and they would make a pretty nice living doing nothing but assisting. I've been in a couple places where there was that setting. But
I'm more talking about like routine everyday stuff, like managing somebody's diabetes, managing somebody's arthritis, like, things that I just see trends, especially, I work with residents and I see they have a tendency to want to just like refer. And I'm like, guys, like, you can manage that, and you should be able to. I mean, I think the systems sometimes are guilty of seeing family medicine as just a referral base, and they don't like that's like, and I will tell students, I get students in with me and I'll say, guys, I'll talk to them about family medicine. I promote it. Like, I really think it's a great career. I mean, it's a pretty good deal. I've got an 8 to 4 schedule. I think it's a very decent living. And I've got like a great lifestyle. And I always tell them, like, you're very employable. Any health system, just back to the point about how health systems really do see family medicine and primary care as most, of them as foundational. And that means that
feeders,
you can work anywhere you want, and you can kind of call the shots. I mean, it's a very highly sought after kind of position these days. Like, every community could only employ so many nephrologists or whatever, you know what I mean? Like, so I just kind of plug that to them as well. Like, think about the lifestyle stuff. A lot gets made of, you'll be, it's not interesting or whatever. I think it's endlessly interesting. And I tell them that, and also just like, it's a pretty good deal in terms of your career. I mean, I think in terms of the hours versus the compensation. Maybe not as good as something like dermatology or radiology, but where you have good hours and you make more money. But
It reminded me of a couple of things. Over the years, there was back in like the 90s, the hospitals were buying practices, and the family practice guys that had big practices, sometimes got really good deals on a hospital by their practice. And then the irony was, half the time the hospital would give it back to them after like 3 or 4 years because they found out that they couldn't make any money running the practices, I know
it's a bit of a challenge. It's like, yes, like they need us, quote unquote, for the referral base, and like it's not the most financially lucrative practice. I mean, that's kind of the trade-off, I think, if you're a health system.
Why don't we talk a little bit about the AI?
AI, artificial intelligence. I think most of the conversations that I have with people, a lot of the conversations, especially doctors, is just how is AI going to like take my job? And yeah, I mean, I think a lot of our work will be taken by AI, but kind of reference our previous discussion about, at least in primary care, our physician shortage. To me, that doesn't mean people are going to lose their job. It's just going to mean, I'm going to be able to do more. It's going to take away a lot of the scut work, if you will, of my job, and allow me to actually do more patient care. So I'm really excited about that piece of it. I see it as as a really, really good medical assistant, or a really, really good scribe, or a really good medical student that is going to take the patient record, kind of condense it, consolidate it for me, and like serve it to me and say, here, doc, like this is what you need to think about. This is what you need to be focusing on today for this patient. And just, I wanted to raise a couple of things that I think you should focus on, So I think that piece of AI, when we get there, where it's a really good digital assistant, I don't think on a society level, people are going to so quickly just jettison the whole institution of a physician in favor of a robo-doc. I mean, at least not for a long time. Right. And I don't really want to be around when that happens. Yeah. But I think just in terms of, I see it as just sort of like a sacred role in our society still, like a priest, yeah. Or I guess to some people they're banker or something. But, just person that you have that fiduciary, trusting human relationship with. I mean, AI doesn't, solve the questions of medicine. It can tell you the studies, the reports, the data, the patterns, the algorithm, but it can't do the things where it's like, well, this particular patient doesn't fit any of those patterns, which happens every single day in my practice. Right. It's like, I'm dizzy. How do you figure out dizziness? It's like, right. So again, I'm actually really, I'm on the side of like, I think this is going to be good in the short term. It's going to make my job easier. The worry there is like the cost, they're going to charge us for this. It's going to be expensive. I think it's going to be, that'll be interesting to see, so will I even be able to use it? I was telling you, I already am using AI pretty much every day. I'm the kind of doctor that I look things up. I will sit there in the room with the patient and I will just look it up. I will say, what, let me look that up real quick. So, and usually what I do is I pull up our current like resource reference, which is kind of like an encyclopedia where you just like do a search and then you pull up an article. Yeah. But I've changed to a new app, and I probably don't want to say product names, whatever, but it's a great app, and you literally, it's almost like ChatGPT, but it's for doctors, and it'll give me an answer to my question, and it will immediately list the articles and references that it's talking about. And I just find it like so helpful, rather than having to go through a whole article and sift through that and find the relevant information. It's giving me what I want to know right away. So I like I said, I already use AI every single day. The other AI piece that people use is in primary care, family medicine, is dictation, or basically writing notes. The idea is like there's this app that's listening to the entire patient encounter, and it's going to generate a chart, an entry based off of that. I'm not using that right now just because my notes, I feel like, are very quick and I dictate them, and I don't think I need that. And again, there's a cost there, but so those are the ways that I see AI being used, and am currently using AI, at least in family medicine.
It's my experience with AI is almost exclusively limited to doing these podcasts, and just by apparently AI, there's an AI assistant listening to us like right now, and at the end it takes them like 20 minutes or so to type it all up, but at the end, it puts up a summary of what we've said. I'll get a summary, and it's pretty damn good, I have to say. It's like, as you said, when you mentioned the word scribe, it was like, it's like a free digital. It's like a free scribe. It really does a pretty good job of saying everything that we talked about.
That we thought we like. It's of course the computer can do that. You know what I mean? Mm-hmm. And like, once you see it, you're like, oh, great. Like, I don't have to worry about doing that kind of task anymore. The way the electronic health record right now is so detailed, it's so dense. The amount of information that we're expected to review for just a simple patient encounter is insane. People put statistics out there about it's like a full like Moby Dick, you have to read every single patient. So, I just find I just think it's going to cut through so much of that BS. Because as we were talking about earlier, like you kind of referenced quickly the whole mandate to do electronic health records,
right,
and how that, drove people out of private practice. And I think electronic health records has kind of been a mixed, bag for us. Like, it's been good in some ways, but it's really made the job harder in some ways, again, with just notes. Like the notes are too long and there's just too much information. So I'm hopeful that AI will just cut through so much of that and just be like, look, I reviewed this whole chart. It took me 20 minutes, but I reviewed every single thing that's in this chart. Here's what you need to know.
Yeah. Oh, well, Joe, hey, I think we're pretty good. I think we can wrap it up. It's really very good, interesting talking to you, and maybe we'll have another one. I have some more podcasts to do, so maybe I'll give you another follow up in a couple months. Okay.
Sounds good. Thanks for involving me, and good luck with the book.
Okay. Thank you. See ya.
All right. Take care. Bye.